Students, good evening. We are going to start about cardiovascular drugs. Till now, we studied about peripheral nervous system. Now we are going to study about cardiovascular drugs, heart-related issues. In this topics, in heart-related topics, first one is diuretics. Hmm? See, drugs, di means double. Uretics means urine. So the drugs which increase urine output are known as diuretics. Diuretics drugs are the drugs that promote production of urine are known as diuretics. They are also called as water pills or water tablets because they increase urine output. So this is it. Hmm? General urine output is 1.5 liters per day, but if you take here, no, it will be increased to 2 liters like that, depending upon the condition of your body. Now, here all diuretics uh, increase excretion of urine. Will all diuretics increase the excretion of urine is nothing but what's the composition of urine? Water. 99% is water. That's why we written excretion of water from the body in the form of urine, mostly by excreting sodium. What they do is that hmm, our body, I told you last time, I think, or first time, let me see. So consider a solution. Solution is nothing but solute plus solvent. Solute plus solvent. Now, in a solution, you consider solute as sodium, and solution as water. Both combines to give solvent which is present, fluid which is present in our body. So wherever sodium is present, water is available there. Wherever sodium is present, water is available there. Even you see in nature also, the amount of sodium present in ocean is more. So all the water will be moving towards ocean. So if you take sodium in our body more, what happens? No, water starts accumulating in our body. So you become obese, fat, like this you will become. So you make sure that your diet doesn't contain more sodium levels. It doesn't contain sodium level. So wherever sodium is present, water is associated there. Because solution is nothing but solute plus solvent. Solute plus solvent. So when sodium is present, solvent automatically moves to there. Now, what our drugs do? What we are telling, drugs which increase urine output. Urine is nothing but water. What they do is that they increase excretion of sodium. They increase, hmm, they increase excretion of sodium from our body fluids. They increase sodium excretion triple times. Whatever it is going than normal, it will be excreted more. Hmm? That is known as diuretic. So they increase excretion of sodium. When sodium is excreted, what happens? Automatically water goes. So there are some ways how our body will excrete sodium. Let us uh, we will study in the further slides. But what is the main use of diuretics? Let us see. They are used in treatment of edema. Edema. Huh? How do you find edema? You see, this is leg from the ankle, no, 1 feet above, 1 feet above. You press, you just apply a pressure on the your leg. If you find depression, huh, for 1 to 2 minutes, then it is nothing but edema. So even now, if I press my leg, hmm, Depression will be for only just 1 second or something, it will come back again. But if you are having edema, you can check with your parents or by yourself. So above 1 feet from the ankle, ankle is this. From the above ankle, if you press, you see in the picture, you are pressing the thumb or finger, whatever matter maybe. If you press, hmm, if the depression is for long period of time, for 2 minutes, slowly it comes to normal, then you are suffering from edema. Edema means what? Accumulation of fluid. Accumulation of fluid. There are many reasons for edema. So one reason is heart failure. When heart is not able to pump, huh, then edema you get. Liver cirrhosis, you see it? In liver cirrhosis, hypertension patients, more blood volume. Hypertension may be due to vasoconstriction, uh, vasoconstriction as well as increase in volume, increase in blood volume. Again, wait, blood volume. What is the composition of blood? Again, 90% water. So when water increases, blood volume increases. When water increases, urine output increases. So in hypertension cases also, water increases in our body. Then in kidney diseases, usual kidneys are organ which excretes urine from our body or excretes waste products. In this all condition, the main symptom is edema. Then one more main use of diuretics is poisoning. In poisoning. So poison, no, if it stays in our body, it produces toxic effects. So if it leaves from our body, whatever poisonous effects will be reduced. See, you see this finger, this leg. You see, and this leg. You observe how edema it is. It is mainly due to elephantiasis, Entamoeba histolytica. That microorganism causes edema. In that condition also we can use this diuretics. So this is some introduction. So what I'm telling now, diuretics are the drugs which increase urine output. How does it increase urine output? By excreting out sodium. By excreting out sodium. Let us learn some kidney function, what it does, then you will understand huh, all the things. See, two important functions of kidney is to maintain hemostasis, hmm, that is electrolyte balance and water in our body. To maintain blood level. Hemostasis means blood level with the help of electrolytes and water. Then to excrete water soluble metabolites. To excrete water soluble um, metabolites. So these are the two important functions carried out by a kidney. Hmm? So one is that it maintains blood volume by maintaining electrolytes and water. Electrolytes means what? Sodium, potassium, chloride, bicarbonate, these. So when sodium levels are brought inside, what happened? When sodium, I told you, sodium is best friend of water. Wherever sodium is present, water is available. So if you take more sodium in your body in food, what happens? You will become fat. You will become fat. So because why no fluid starts accumulating. So one more use is that you see, excuse me, one more is to excrete water soluble metabolites. To excrete water soluble metabolites. Now see, you know this statement: 1 million nephrons are there. This is a functional unit of a kidney. uh, 1 million nephrons are there, which is having capability of forming urine independently. Functional unit of kidney is nephron. 1 million nephrons are there. Each nephron is able to produce urine. Then, what are the parts of nephron? Why we are telling, mechanism of action depends on this part. So some drugs will block at glomerular, some drugs will block at proximal convoluted tubule, loop of Henle, distal tubule. So these are the parts our nephron. So let us go to hmm? Next slide. We can see it. See, approximately 1200 ml of blood per minute flows through both kidneys and get purified. 1200 ml of blood flows per minute. Per minute, how much of blood? 1.2 liters of blood is flowing through the kidney, huh? And gets purified. Whatever the toxic substances are there, it gets excreted out. Gets purified. Then you see what is the beautiful thing about kidney is that, see, ions such as sodium, chloride, calcium are reabsorbed. It will be reabsorbed from the kidney. All the metals, everything will be reabsorbed from our body. From our body means with the help of kidneys. And also you see, it also reabsorbs, which one? Kidney. It also reabsorbs glucose, amino acids, vitamins, proteins completely. You will not, if you are healthy, no, your urine doesn't contain glucose. If you are healthy, your urine doesn't contain amino acid, vitamins, proteins. If you are having some health issues, then only you will find these glucose, amino acid, vitamins, and proteins are found in urine. These sodium, chloride, calcium are generally they are found. That is not the issue. Hmm? Now, for example, you see, if proteins are found, example proteins such as albumin is in higher amounts, then it is albuminuria. That means albumin in urine. It is. If you find glucose, it is nothing but diabetes. It is nothing but diabetes. So kidney, what it does is that what are the important components are there in the food, it will completely reabsorb. See, I'm using word again, reabsorption. Reabsorption, I'm not telling the word absorption. Absorption is done in the stomach once. So after taking food, your food reaches to the stomach, huh? It is absorbed into the blood, to the body. Next, again, the process of absorption is done in kidney. That's why we are telling as reabsorption. It is called as reabsorption. Already absorption is done in the stomach villi, at small intestine, it is done. But absorption is again done at the kidney level, at nephron level. So that's why we are telling reabsorption. So all the food materials, body will reabsorb. It will try to conserve, reconvert, conversation process, they'll tell, no. So it will try to take out all the food material, so it only takes waste product from our body. So this is just introduction. So let us see what in our nephron, what it does, you see, sodium excretion and regulation, you can see it. Sodium excretion and regulation. So for example, if this is nephron, the first part is Bowman capsule or glomerulus. So blood from efferent now. So for example, if this is input, it comes here. So it's filter here. It filters here. So some fluid comes into the glomerulus. It comes to the glomerular. So what are the filter it is coming here? Filtrate. Huh? Now let me go to next slide. Huh? Now you see this is nephron structure. So whatever the some efferent now, this is excretion. So whatever the fluid coming here from the blood vessel are capillary. So what happened? Fluid enters to this part. This is called glomerule. Glomerulus. This is nephron. So what happened when fluid comes to here? Proximal. This is called as proximal convoluted tubule. So bent very close to the glomerulus. So that's why it is called as PCT. See what it does. You see when it comes to glomerulus, 62. We are considering only about sodium. We are only considering about sodium. You see, 60 to 70% of sodium is reabsorbed. What it is doing? Sodium, it is taking reabsorption is done by our body. Where? At proximal convoluted tubule. We'll come to drugs afterwards later. Hmm? So, what is the pump? See, this reabsorption is done by some process that is called as pump or transporter. So the transporter which is working at proximal convoluted tubule is sodium potassium hydrogen antiporter. Antiporter means, for example, if you consider this glomerular, sodium comes inside and hydrogen H plus will go out to the urine. You consider this is a wall, nephron wall. So this is our blood vessel, which is in red color. So what happened? The sodium which is present inside filtrate of glomerulus is taken back, and the proton which is present in the blood is gone out. So that's why you see the pH of urine is acidic in nature. The pH of urine is acidic in nature. That's why our urine should be acidic in nature. Why? Because of this transport. So here you see one ion is coming inside, one is leaving the body. So this is called as antiporter. I think you people might have learned in anatomy, physiology, all this. It is sodium hydrogen antiporter. Now, when it comes to loop of Henle, the scientist loop has found. So this is a loop of Henle. So this is a bent like structure it was. So loop of Henle. What happened is that hmm, the remaining, here you see what we told, 60 to 70% remaining amount of sodium is reabsorbed. 20 to 30% of sodium is reabsorbed. How? By sodium potassium 2 chloride symporter. Sodium potassium symporter. Symporter. Then DCT, distal convoluted tubule. Here proximal, near, it is long somewhere. So 5 to 10% of sodium is reabsorbed. Then how? By sodium chloride symporter. Sodium chloride symporter. Collecting drugs, 1 to 3% is reabsorbed here by epithelial sodium channel. Epithelial sodium channel. So here you see, if sodium is not reabsorbed, what our body is doing? It is sodium is reabsorbed everywhere. Sodium is reabsorbed. Suppose if sodium is not reabsorbed, what it does? If sodium is not reabsorbed, it gets excreted. So when it gets excreted, automatically what it takes along with its friend. Who is its sodium friend? Water. For example, if you are two friends are thick friends, so if you are having intention to go to movie, he will take other companion also with him. So when sodium excretes, water also excretes. You don't have intention to go to Tikka Mall, TRM. But when if your friend tells that let me go, so consider your friend as sodium, you as water, both will go. So now see, all our diuretics will block this reabsorption of sodium. So when it blocks, so if consider this is the uh, what is that, glomerulus, and this has a blood vessel. This red is blood vessel. So whatever the sodium which is present in uh, lumen of what is that, nephron, is reabsorbed. In proximal conductor 60 to 70%, loop of only 20 to 30%, distal conductor 5 to 10, collecting ducts 1 to 3. Remaining whatever it is present will go out. So what are the drugs which block, you see? Proximal cannulated tubule, carbonic anhydrase enzyme inhibitor, carbonic anhydrase inhibitor, loop of Henle, loop diuretics, distal cannulated tubule, thiazides, collecting ducts, potassium sparing diuretics, potassium sparing diuretics. So these are the drugs. This is the way this chart tells about the how sodium is reabsorbed, what pump, and what are the drugs where they are you drugs where they act. Loop of Henle acts at loop diuretics act at the loop of Henle. Collecting ducts, it is potassium sparing diuretics. Distal convoluted tubule, thiazide diuretics. PCT, carbonic anhydrase inhibitors. Carbonic anhydrase inhibitor. So this is, see now. So whatever the fluid, imagine this diagram whenever we are telling. So here all blood vessels will be there. So whatever fluid is present will be entering to blood vessel. Whatever it is not reabsorbed will move throughout this lumen of nephron. It will be moving to this place. So finally, it goes out as urine. It goes out as urine. So let us go. We'll go fast. So classification of drugs. Classification of drugs. Carbonic anhydrase inhibitor. Carbonic anhydrase inhibitor. What are the example? Acetazolamide, methazolamide. Acetazolamide, methazolamide. So high ceiling, high ceiling or loop diuretics. High ceiling or loop diuretics. Examples you see: furosemide, furosemide, torocimide, bumetadine, bumetadine. All these drugs, you see, all these drugs are classified under loop diuretics. What are the derivatives? Is sulfonamide derivatives. Sulfonamide group means SO2 NH2 group. That group is available for this. Then non-sulfonamide derivatives. Examples is ethacrynic acid. Ethacrynic acid. So under loop diuretics, two class of drugs: sulfonamide derivatives, non-sulfonamide derivatives. Then thiazides, which is acting at distal convoluted tubule, chlorothiazide, hydrochlorothiazide, metallo, metallo, metallozone. Then potassium sparing diuretics, spironolactone, amiloride, triamterene. Then one more drug, osmotic diuretics, mannitol glucose. We didn't mention mm, in previous slide. We didn't mention about osmotic diuretic. Osmotic diuretic no can act at every center, but especially more at the proximal convoluted tubule it acts. Let us see. Then carbonic anhydrase inhibitor. These are, see how many uses I told you. Know you can find these drugs. Suppose if your parents are suffering from hypertension, or heart failure, or liver cirrhosis, kidney problem, they'll be using these drugs. So please learn now onwards. It is related to your heart. Now you see the carbonic anhydrase inhibitors. First, they found in sulfanilamide. What is the drug? Sulfanilamide. This is the structure of sulfanilamide is this drug. Hmm? The main use of the sulfonamide is antibacterial. It is antibacterial drug. Antibacterial drug. This is antibacterial drug. So what happens is no in 19, 20, 30 during World Wars, during that time, this drug has saved us like anything. So the people who during injuries, no, they used to apply this drug or ointment ways or by tablet. When they take this, they found most of the people are having side effect of frequent urination. What they observed is that frequent urination. Then they done some such structural. See, it is a side effect of this sulfonamide. What is that? Sulfonamide main use antibacterial. What is it? Is antibacterial, but its side effect is what? Frequent urination. Frequent urination. It was shown. Now what they done is that they done some structural changes such that the antibacterial activity is reduced and this urination property is increased. See, this is called as optimization of side activity. So what they are doing is the primary pharmacological action is this is primary pharmacological action, and this was secondary pharmacological action, and which is side effect. Now they minimized or they reduced antibacterial activity and increased diuretic activity. Increased diuretic activity. That's why, uh, though they are having sulfonamide group, they improved the diuretic effect. And when they done research, why sulfonamide is having diuretic effect is that they found that it is blocking one enzyme, carbonic anhydrase enzyme. Carbonic anhydrase enzyme. And the ability of this drug to block this enzyme is less. That's why you are getting urination, frequent urination, you are getting not more. That's why the sulfanilamide is a has weak diuretic effect. So diuretic effect is weak. Now, what they done to get diuretic effect is that, let us see. So students, any doubt up to here? Please.
No doubt, sir.
Okay, thank you. Clear now? So what is the primary action of sulfanilamide? Antimicrobial. So they minimize the primary pharmacological activity and increase side effect. What they done, you see? And now see some of the research they done. What they observed, you see, sulfanilamide is one drug. There are nearly 20 to 30 sulfonamide drugs available. 30 to 40 sulfonamide drugs are available, but no other sulfonamide is producing diuretic effect. Only which sulfanilamide, the first drug, is producing diuretic effect. Huh? For that, I will tell why that is the reason. Let me tell afterwards. Now you see. What they done is that they changed this benzene group with some heterocyclic ring. And I told you many times, we are reading only successful stories, not the failure stories. So straight away, so when benzene was replaced with thiazole, thiazole, what thiazole? 1,3,1,3,4 thiazole. When sulfur and nitrogen is present, which one should get preference first? We learned sulfur. So one, two, three, four. So now you see 1,3,4 thiazole, thiazole. The first one is related to sulfur. Next 3 and 4 is related to nitrogen, thiazole. So when it is replaced, no, benzene is replaced with thiazole. What happened? We got acetazolamide. Acetazolamide. Then, when there is methyl group on the third nitrogen, we got methazolamide, which is more active. Now here you see the sulfonamide group. This is sulfonamide group is intact. There is no change. What they done is that they replace this benzene group, and on the nitrogen acetyl group they have added acetyl group they added. This caused what happened. Because of this, what happened, the primary antimicrobial activity is reduced, and the secondary pharmacological action, that is diuretic effect, is improved. So we get diuretic effect. So now itself I want to tell why sulfanilamide, only sulfanilamide is showing antibacterial, showing diuretic effect, not all sulfonamides. See, let me tell you again here. There is one class of drug called as sulfonamides. Sulfonamides. Sulfonamides means drugs which is having SO2 NH2. One example for sulfanilamide is sulfanilamide. So among sulfonamides, only sulfanilamide is having diuretic effect, not all the drugs. Why? Because is that in sulfanilamide there is no substitution on SO2 NH2 group. All sulfonamides have substitution on this nitrogen. So all our drugs, if they are acting by carbonic anhydrase, there is no substitution on SO2 NH2 group. SO2 NH2 group. If there is substitution, what happened? Diuretic effect is lost. Students, are you getting any doubt here? Clear?
So could you repeat the one for NH2 replaced with acetyl? It does what?
Here amine group has been replaced by acetyl group. One of its hydrogen has been replaced by acetyl group. And there won't be any substitution on sulfonamide group. What is this group? Sulfonamide group. Yesterday also we have seen, you see, in alpha 1 blocker, sulfonamide groups. What is that group? What is that drug? Mm, tamsulosin. Tamsulosin is having sulfonamide group. Here if there is in diuretics, no, SO2 NH2 group is not substituted. All our diuretics, there won't be substitution on SO2 NH2. Here there is substitution, acetyl group, and the benzene ring has been replaced by other heterocyclic. Now let me make it clear. In sulfonamides, there are 30 to 40 drugs which is having antibacterial activity. The first discovered drug is sulfanilamide. This is the first drug which they discovered under this class. Only this drug is having diuretic effect. Is it okay?
Yes, sir.
Any others, please? Students, oh my god, you're angry on me. Aston, Aston,
Present.
any doubt, madam?
No, no doubt.
Okay, next. Hmm. This is structural activity relationship. Already we discussed. See, in structural activity relationship, acetazolamide is prototype. That means in carbonic anhydrase, this is the starting drug. Here you see the sulfoamyl group, SO2NH2. You can tell sulfonamide group or sulfoamyl group is essential for the production of diuretic effect. This group is essential. So all our diuretics will be having SO2NH2 group. And what is most important thing is that there won't be any substitution on the nitrogen. It will be as such SO2NH2 group. Then if there is any methyl substitution, then it increases activity. We got one drug called as metazolamide. Then even this acetyl group has to be present. Acetyl group also should be present. This is SAR of these drugs. The same thing, whatever I explained here, you can see it. See? Huh? The sulfamyl nitrogen must remain unsubstituted to induce diuretic effect. This feature explains why all antibacterial sulfonamides except sulfonamides are incapable of inhibiting carbonic anhydrase or exerting a diuresis. Exerting diuresis. Now, here, this is metazolamide. Without methyl group, it is called as acetazolamide. If there is methyl group, it is methazolamide. This is more potent carbonic anhydrase inhibitor. We learnt in first slide. These drugs block carbonic anhydrase inhibitor. So what they do is that you see, when it inhibit carbonic anhydrase enzyme, next slide we will learn what its mechanism. So what happened? Fluid will go out. So urine output increased. Now, apart from this diuretic effect, the main important of use of this methazolamide is used in treatment of glaucoma. This drug is used in treatment of glaucoma. Why? Because it it has better penetration in the eye. Penetration power of this drug in the eye is more. In the eye is more. So this is methazolamide. Now coming to mechanism of action. You consider now this portion. This is lumen. Lumen is nothing but inner portion of any pipe generally. Now you consider this is lumen of nephron, and this is the cell membrane. The cell membrane, what the entire this the cell membrane. Now coming to here, see, start from here. Now carbonic anhydrase, what it does, you see, it wherever, so whenever there is present of water plus carbon dioxide, our body is having water and carbon dioxide abundantly. When these two combine together in presence of carbonic anhydrase, we can write as Ca, carbonic anhydrase as Ca. In presence of carbonic anhydrase, what you get is H2CO3. You get carbonic acid. H2CO3 is known as carbonic acid. So now, if there is no carbonic anhydrase, what happens? No, water and carbon dioxide cannot react to form carbonic acid. You people should understand. Water and carbon dioxide is available in our body plenty, but both cannot react. When they two can react, only in presence of carbonic anhydrase enzyme. Only in presence of carbonic anhydrase enzyme, it is converted to carbonic acid. Carbonic acid. What is the carbonic acid? H2CO3. Now, this H2CO3, what happens? No, it immediately dissociate as H plus and HCO3 minus, HCO3 minus. It is called as bicarbonate. It is called as bicarbonate. This bicarbonate will give coating to the cell membrane to protect us from the acid, to protect us from the acid, and make our blood vessel alkaline in nature, because bicarbonate is alkaline. So when there is no carbonic anhydrase, there is no carbonic acid is formed, and there is no dissociation. See, this process is rate limiting step, that is conversion of water and carbon dioxide to carbonic acid. But conversion of carbonic acid to proton and HCO3 is not a rate limiting step. It simultaneously occurs. It simultaneously occurs. Now come to our picture. Now you consider here, you start from here. It will be very easy. Now you see, water is reacting with carbon dioxide to form carbonic acid. Carbonic acid. Now once formed carbonic acid is dissociated as H plus and HCO3. This is bicarbonate which is entering into blood. That's why we get alkaline pH. Most of the times our blood pH is slightly basic in nature. Now you see the released proton here on the cell membrane. What happened? No? It will be released to the lumina nephron. So because of this proton release, so our body, our urine pH is acidic in nature. So our urine should be acidic in nature. Otherwise, no, if it turns into alkaline, you get more infections. You get more infections. You can yourself can identify uh, mm, by color of your urine. If the urine color is yellow, yellow, normal color of urine is pale yellow color. If it is yellow in color, that means indicates that your urine is alkaline in nature. When it becomes alkaline in nature, you are 100% chance of what is it, bacterial infection. Bacterial infection. Again, you see, compared to men, women are more prone for bacterial infection, urinary tract infections. Why? Because of genital reason. So the what is it? Rectum and vagina are very close proximity to each other. So that's why, you know what happened. The microorganisms which are present in rectum can move to the vagina. So they produce more urinary infections. So now let me come to here. So during the process of leaving out of proton, efflux of proton, what happens? Sodium is influxed. Sodium is influxed. So this is called as antipode. So one is going out, one is coming inside. And this process, all this process is catalyzed by this carbonic anhydrase engine. If you block here, there is no what is that proton, and no reabsorption of sodium, and no excretion of proton. So when you block here, what happens? What happens? You see, whatever the sodium is present in lumen will be excreted out. So from proximal convoluted tubule, it leads to loop of Henle. In the first line, we learned what is the percentage of sodium reabsorbed here. 60 to 70%. You see, 60 to 70%. If you block that step, no, what happens? 60 to 70% will move to loop of Henle. If you block here also, if you block here, what happens? All the sodium is reacts will prevent reabsorption and get excreted out. Will be excreted out. So this is the way how this drug is acting. This drug is acting. So that's what you see. When you block this process, now what happens? Sodium is as much as present. Hmm? So it blocks sodium potassium. This results decrease sodium reabsorption and increase urine output. So what happens is that bicarbonate accumulation occurs. So as proton is not coming, proton is nothing but acidic. So what becomes your urine becomes alkaline in nature. Your urine becomes alkaline in nature. So this is a then what are the uses you see? It is used in treatment of glaucoma. Glaucoma is also fluid accumulation. So if you in eye also what happened? There also in eye we have carbonic anhydrase enzyme. Carbonic anhydrase enzyme. So water will react with carbon dioxide and it bicarbonate is formed. So water accumulates there. Then you see one more part you see alkalization of urine. So it is causing. So in previous slide we learned that urine becomes alkaline in nature because there is no proton here. So what happens is that you see urine becomes basic in nature. So this will because of alkalization what happened will excrete acidic drugs. So it is like acid base reaction. Our urine is base, our drugs are acid. So acid base reaction what happened? You get salt and water. So acidic drugs will be excreted out more faster. Acidic drugs will be excreted out faster. What one example is aspirin. All NSAIDs having carboxylic acid, they can be excreted out fast. Then one more use is it is used in treatment of mountain sickness. Mountain sickness, especially the if you are going to Mount Kenya, what is it? Climbing that mountain. You need to have some professionals. Otherwise, no, if I go here at some level, about 3000 meters, what happen? I get giddiness, vomiting sensation, hypotension, you get almost. Sometimes, if it is not treated, you get pulmonary and cerebral edema. Lungs will get accumulated by fluid. When fluid is accumulated in lungs, now what happen? Uh, you can't breathe, you will die. In that condition we can use this acetazolamide. In acetazolamide, then it is also used in treatment of epilepsy, in treatment of petit mal and unlocalized seizures. So this is about carbonic anhydrase enzyme inhibitor. So students, any doubt please?
No
Srina,
doubt.
Hiral, Srina, anyone please tell me.
No doubt.
No doubt.
Hmm. Hmm? So it's 4:30, 5:30. Let us finish this. Now, another drugs. Now we are coming to loop diuretics. These are called as high ceiling diuretics. With these drugs, now what happen? More urine goes out. That's why they are called as high ceiling diuretics. Here also you see, observe SO2 NH2 group is there, sulfonamide group or sulfonamide group, no substitution. Now, what are these diuretics you see? Uh, these are loop diuretics or chemically they are anthranilic acid derivatives. Anthranilic acid means benzene having amine group and carboxylic group side by side. If benzene with hydroxyl group, what it is called? Hydroxyl group catechol. This is catechol. Now here if there is amine group and carboxylic group, this is anthranilic acid derivatives. Anthranilic acid derivatives. Now here you see the numbering starts from carboxylic group 1, 2, 3, 4, 5, 6. Now, yes, yeah, please. Hmm. The substituent at one position must be acidic in nature. It should be acidic. The carboxylic group provides optimum diuretic activity. Carboxylic group can be present, or with other acidic groups like tetrazole also can be present. Instead of carboxylic group, you can also add tetrazole. Hmm, tetrazole is having 4 nitrogens in 5-membered ring circle. So the proton can be easily donated. So the drugs acid is one which donate proton. So tetrazole is also acidic in nature. Then sulfamyl group at fifth position essentially for optimal for diuretic effect. It is essential. So carboxylic group and SO2 NH2 group. Now X, regarding X, it can be chlorine, trifluoromethane. Chlorine can be there, trifluoromethane can be present. But among these two, chlorine is the best drug, is the best functional group. Next, mm, see now if phenoxy, what we told you here on the nitrogen second position we placed R. This can be varied. This can be varied, that we are going to study. So what they can do is that you see a phenoxy, a phenoxy, alkoxy, aniline, benzoyl substituent at fourth position can also be. No need this. Next you see regarding this. The substituents that can be tolerated on second amino group can be furfuryl. This is furfuryl group. Up to here, if there is no this, what is this group? Furan. Furan. When there is methyl group, methylene group, then it becomes furfuryl group. Furfuryl group. So the best drug available in this class of drugs is furosemide. Furosemide. You say furfuryl group is present here, carboxylic group is present, sulfonamide group is present, and chlorine group is present. Ah, azoximide. This is one drug. Azoximide. Azoximide. Here, what happens? You see, at the first position, instead of carboxylic group, there is tetrazole. See, I was telling that 4 nit in 5-membered ring, 4 nitrogens are present, and this proton is there. Now, this proton is easily donated. So the ability of donation easy, more acidic in nature. See, 4 electronegative atoms. 4 electron. So this is easily donated. So more acidic, equal to that of carboxylic group. pKa value will be equal to that. Hmm. That is. One more is, you see, on third position. Here, this is bumetadine. Bumetadine. On third position, instead of second position, third position, there is butylamine group. Butylamine group, which is called as bumetadine. It's called bumetadine. Then what these drugs you see? These drugs block sodium potassium chloride symporter. Sodium potassium symporter. See, this is lumen of what is that? Our nephron, which consists of urine color. Here, what happens is that in at a loop of Henle, sodium, potassium, and 2 chlorides all are moving the same direction. That's why it is called as symport. So our drug, what it will do is that it blocks this process. So when it blocks this process, what happens? The sodium will not enter into the blood. So when sodium is not entering into blood, what happens? It is present in the urine. Next, it will pass to from loop of Henle, it pass to distal convoluted tube. Next, get excreted out. So this is the mechanism of this. So here you see, now we are telling, we can tell some textbooks they write as sodium potassium 2 chloride co-transporter. So they mention as N for sodium, K for potassium, 2 for chlorine, one C for chlorine, another C for chlorine, and this is 2. They write NKCC2. Here you see, this is NKCC2 pump. So this is the mechanism of loop diuretics. Then, what are the uses of furosemide? See, furosemide is the drug of choice for emergency situations. When fluid accumulation is more, we can use this drug. So in acute pulmonary edema, hmm, we know, no, you consider this is hot. Consider this is hot. Now what happens is that from here, from here, sorry, from right ventricle, what happened? The impure blood will move towards lungs. From lungs, from left atria, you get pure blood. So if there is failure in left ventricle, what happened here? Fluid starts accumulating. Fluid starts accumulating in left ventricle, then in right ventricle, then what happened? Even in the lungs. So you feel difficulty in breathing. So if more fluid is accumulated, then we can use this drug as drug of choice. You get urine more. Then, to lower peripheral edema, we will learn all this next. Next, edema due to nephrotic syndrome, kidney failure. Then, in acute hyperkalemia, we can use this drug. Then, in hepatic cirrhosis with ascites. Ascites means the first picture which I showed you. I think you people might know this all. Hmm? This is called as ascites. Collection of fluid in the abdomen is called as ascites. Some people know, especially gents, they'll be having stomach like a pot, hmm? like pot in their stomach. This is nothing but because of liver issues, ascites. This is called as ascites. Collection of fluid in the abdomen. In that condition, we can use. Hmm? We can use that. Then in treatment of hypercalcemia, hmm, especially occurring with hyperthyroidism and malignancy in cancer, calcium gets accumulated. In that condition, we can use. What are the side effects? Hypokalemia, potassium loss, because see why sodium, potassium. Potassium is also blocking, so potassium loss occurs. So we are telling we can use in acute hyperkalemia. If levels of potassium is more, if you take this drug, what happens? No prevention further. So what is the side effect? Potassium loss occurs. So that is the side effect. Then fluid electrolyte losses. More fluid goes, no. That's why fluid electrolyte losses occurs. So blood volume. So reduction in plasma volume. If you are using long term, then sometimes you get urticaria, fever, intestinal nephritis. This the reason we don't know. These are the side effects of these loop diuretics. So let us learn one synthesis. Synthesis of this drug. So the starting material for the synthesis of furosemide, very important. So I given the synthesis. So here, benzoic acid. This is benzoic acid and it is having two chlorine molecules. Where? 1, 2, 3, 4. So 2,4-dichlorobenzoic acid, 2-chlorobenzoic acid. When treated with chlorosulfonic acid and ammonia, what happened? You get sulfonamide group. Why? This is meta director. Carboxylic acid is meta director. So at meta position, you are getting sulfonamide group. Then treat with furfuryl amine. Up to here we told furfuryl. Up to here it is furan. This is furan. Up to here furfuryl. Now there is amine group here. Furfuryl amine at 130 degrees. At 130 degrees. So you get this structure. So chlorosulfonic acid, ammonia. If both, you get sulfonamide group or sulfonamide group. Then next is that almost we got the structure of furosemide. Only here we have to change. So in order to move that chlorine atom, what we are taking now, we are taking for furyl amine. Now one of its H and Cl will go as hydrochloric acid and it will be attached. So whatever the changes we have made in different color, we made it in the different color. You can learn like that. Next, uh, now thiazide drugs. Another class of drugs are thiazides. See, these are very important. So that's why I am telling everything. In previous drugs, now one or two drugs I used to tell two, three classification. When there are four or five classification, one, two I will tell. Now I am telling everything very important. That's why. Very important. No, another half an hour, please. We can finish. Now, thiazide drugs. Thiazide drugs. See, as nitrogen, thiazine. Mm, so let me tell. The basic structure. The basic structure is 2,4-benzodiazine. Diazine. See, so one is sulfur, 2 4 position. Where is the nitrogen position? At second and fourth position. So to this benzene is attached like benzodiazepines. Like now here is benzodiazine. As means nitrogen, ion is 6-membered ring. So 6-membered ring this is thiadiazine. At which position? First position sulfur group, and second position is nitrogen, and fourth position is nitrogen. So 1,4-benzodiazine structure. The basic structure of thiazides. Then now you see we have seen numbering. You see 1 sulfur first preference, next nitrogen, 2 3 5 6 7 8 8. So this is the numbering of thiazides. Now first we are going to see about between 3 and 4 position. 3 and 4 position. So here no saturation of CN bond, that is 3 and 4 of benzothiadiazine increases the potency. When you saturate this bond, you increase the activity. How many times? 3 to 10 folds. The reason is not known. Why it is so, we are not able to tell the reason. You see here? Now, this is the basic structure we learned. Now, here you see chlorothiazide. If chlorine is present, it is called as chlorothiazide. Now, you see the double bonds between C3 and N4 If it is saturated and having chlorine, it is called as hydrochlorothiazide. Hydrochlorothiazide. Two hydrogens have come, so that's why it is called as hydrochlorothiazide. This is more active than chlorothiazide. There, instead of chlorine, if there is trifluoromethane, trifluoromethane, then it is called as hydrofluomethazide. 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 Here also is saturated. So these two drugs are more active than chlorothiazide. Next, next you see substitution at 6. Next position you see substitution at 6. Substitution at 6 with electron withdrawing group. Now here you see trifluoromethane. Electron withdrawing group is essential for activity. Chlorine is also electron withdrawing group. Fluorine is also electron withdrawing group. Like fluorine, chlorine, all halogens. Nitro group also we can use. Can also reduce. The best substituents at 6th position is chlorine and trifluoromethane. If there is methyl group at 6th position, it loses activity. It reduces activity. Now, substitution at 4, 5, 8. In those picture you see, 4th position, 5, 8. Here also, 4, 5, 8. There is no substitution. Any drug is no substitution. 4th position, no substitution. 5th position and 8th position. So there should not be any substitution here. Any substitution here. Then SO2 NH2 group is essential. Substitution should not be present. That we know. Substitution in 3 position determine the potency and duration. Now, 3rd position is what? SO2 NH2. Here, hydrogen. Here you see there is bendroflumetazide. But here benzyl group is present. Benzyl group is present, which is more active. The substitution at 3rd position determines the potency and duration of action of thiazide. The 2nd position, even methyl group, if it is there, also okay. Methyl group, if it is present, also okay. For example, metazole, metalozone, and there is benzyl group here. This is also okay. Is also okay. Then examples you see metazolone. Metazolone. This is the drug metazolone. Here what happened? The 2nd position there is again aromatic ring. Instead of hydrogen there is aromatic ring. That is also very good. That's also good. Now you see this drug metazolone is a thiazide like diuretic, which is having trade names Diuretics. It is primarily used to treat congestive heart failure and high blood pressure. This drug, in heart failure patient, it is more prescribed. Metazolone. Metazolone indirectly decrease the amount of water reabsorption into the bloodstream by kidney, so that the blood volume decreases and urine volume increases. This lowers blood pressure and prevents excess of fluid accumulating in the heart fluid. Now, this metazolone sometimes combined with loop diuretics like furosemide or bumetidine, which is highly effective. But what happens, it causes severe dehydration. If you combine this drug, no, heart failure patients, no, we can't tell what drugs are best, how to do it, how to treat it, how to treat. Why? Because now, in one condition, if fluid starts accumulating, they feel difficulty in breathing. If they give more diuretics, they feel thirsty. So they will be taking more water again. Urination will be more. Already they are suffering from difficulty in breathing. So they need to go to washroom frequently because of these diuretics. So this is the one pitiable condition, no, where like I told you, no, I told you last time, diabetes plus TB. If it is come, it is a deadly combination disease. Same way here. Diuretics you are giving more urine output. So when you more in urine output is there, more thirsty. If they drink more water, they feel difficulty in breathing again. So this is the disadvantage with this drug. Then mechanism of action of these drugs. Here they act at the thiazide, no, distal convoluted tubule. They act at the distal convoluted tubule. Let me show you the. If you can remember this slide, no, this slide. So it is according to the parts first. Classification is also done according to the first. Carbonic anhydrase are acting at the proximal convoluted tubule. First part immediate to the Broman capsule or glomerular capsule. Next part is loop of Henle. So let me go to next slide. You can understand. The first part is proximal. Next part is loop of Henle. Next part is distal convoluted tubule. Next is collecting duct. So this is the way you can remember easily. Now thiazides, how they act, you see. They block this sodium chloride pump. They block sodium chloride pump. Here you see sodium chloride co-transporter. Co-transporter. This is the pump, NCC. They block this pump. So what happens is that sodium will be present inside the lumen. So it goes out. It goes out. Then one more is that increase potassium magnesium excretion. They are also I don't know. So increase potassium magnesium excretion and decrease calcium excretion. So thiazides inhibit renal excretion of calcium 50 to 100 milligrams. Inhibit renal excretion. So what happens is, no, kidney stones or formation for with this drug is more. Next, what are the uses? So diuretic effect in treatment of edema, heart failure. Then one more use is that in treatment of diabetes insipidus. Then uh, due to lowering of blood volume. So in diabetes insipidus, frequent urination, blood volume will be lowered here. Then adverse effects: hypokalemia, calcium, hyperuricemia, uric acid is increased. Then reduction in glomerular filtration rate, hyperglycemia. What happened now? Blood sugar levels are increased with these diuretics, and increased risk of ovarian cancer. So you need to take care of these two side effects with these thiazide diuretics. So last two drugs, please. This is the this is the synthesis. These drugs are also prescribed more. Here you see what is the starting material is chloroaniline. Chloroaniline. Up to here it is aniline and chlorine is the chloroaniline. Here you can see it. This is treated with chloroaniline is treated with chlorosulfonic acid. Then we get chlorosulfonic acid, two molecules. Chlor. Now treat with two molecules of ammonia. You get sulfonamide. In previous in furosemide, what I told you, see, in furosemide, I told this two step at a time. Now here you see what I done is that I made it as separate process. I made it here as a separate process. Once I added chlorosulfonic acid, then I treated with ammonia. Both ways you can write. Now, what happens here? When you treat with ammonia, with the loss of hydrochloric acid, you get sulfonylamide structures. Now, treat this compound 4-amino. This is 4-amino chlorobenzene, benzene 1,3-disulfonamide with formic acid. When you treat with formic acid, what happens? No, you get chlorothiazide. When you treat with formaldehyde, you get hydrochlorothiazide. Saturated one you get. When you treat with acid, you get unsaturated double bond between C3 and CN4. You get. When you treat with formaldehyde, we get hydrochlorothiazide. Hydrochlorothiazide. These are the two methods. Otherwise, no, you can prepare chlorothiazide. Then chlorothiazide is reduced to get hydrochlorothiazide. So these are the ways you can prepare chlorothiazide, hydrochlorothiazide. It's the same material. What is the starting material? 3-chlorosulfonic acid. 3-chloroaniline. Then sulfonic acid you treat. Then treat with ammonia. Then treat with formic acid, you get chlorothiazide. If you treat with formaldehyde, you get hydrochlorothiazide. Or once chlorothiazide is formed, you can reduce by hydrogen, you get hydrochlorothiazide. So this is next. One more drug. These are extra drugs, and this is im- indapamide, which is called as survivor. See the name itself, the name of drug itself is survivor. Is like a thiazide structure. Actually, they are not thiazide drugs, like thiazide like. They are generally used in treatment of hypertension as well as heart failure in acute and sudden. Combination preparation with perindropril. One more drug, perindropril. We can use this drug in the form of with perindropril. Then indapamide is more effective than thiazides for reducing the risk of heart failure, stroke, and heart failure with high blood pressure. These are extra drugs, but very important diuretics. Next, one more drug, chlorothalidone. What is the name of this drug? Chlorothalidone. This is also, see, uh, like thiazide like structure. It has indolin structure. You see what is this drug? This group is indolin. Indole dione. There is ketone group. Indole dione structure is present. This is also chlorothalidone is a prescription drug used to treat high blood pressure, thus prevent stroke, heart attack, and kidney problem. It is more effective in reserving enlargement of main pump chamber in the heart. If there is enlarged left heart failure, we can use this drug. It also reduces extra salt and water in the body. Then it is used in treatments of menstruine disease. Hmm? Menstruine disease, disorder in the inner ear that can lead to de- disease smells, vertigo. In that condition, we can use this drug, menstruine disease. Then it is also used to treat kidney stones. This, huh? These are these two drugs. You people can when you go to hospitals, you can find prescribing these drugs. So remember that. Then last but one, potassium sparing diuretics. Huh? So here you see this name itself. You see in the body, Uh, see, suppose if this cell, sodium concentration outside the cell is more, the potassium concentration in the cell is high. So potassium is very important for us. Compared to sodium, potassium level should be more in our body. If there is no potassium in our body, there is chance of death. There is chance of death. And all our diuretics, till now what we have seen, whatever we have seen, you see, let me go to that first slide. What they are doing, you see, they are carrying potassium along with, they are carrying potassium along with sodium, potassium, sodium chloride important. Even DCT also, it was showing potassium diuretic. So these diuretics, no, potassium sparing diuretics, what they do is that they prevent potassium loss. Potassium loss. So especially for in heart failure, we are giving furosemide. Furosemide is causing hypokalemia. It is causing potassium loss. If you combine this furosemide with these drugs, very good combination. So one drug, it is able to send potassium, but these drugs will try to prevent. So it is very good combination, life saving drugs, especially in heart failure conditions. They what they do, the name itself is sparing. They prevent potassium loss from our body. Examples of drugs is steroidal drugs, aldosterone antagonist, which is spironolactone. This is steroidal nucleus. Direct acting diuretics, triamcinolone amiloride. Amiloride. Now, see, these agents are not potent diuretics when used alone. When used alone, but they usually combine with thiazides. Example is aldacetazide. Aldacetazide. So that's why they're usually combined together. So any doubt, please? Any doubt, please? Another 5 it is 5:15. I will you. Please don't go. 5:15. Another 10 minutes. Now you see these drugs are acting at the collecting ducts. Collecting ducts. The epithelial sodium channel. This is called as epithelial sodium channel. ENAC. Epithelial sodium channel. What it does is that sodium, it is entering. Now here you see, wait, I'm also getting headache. Now you see aldosterone. We have classified these drugs. You see aldosterone antagonist. What does aldosterone does? You see when aldosterone levels are increased, what happens is that it increases the efficacy of epithelial sodium channel. Epithelial sodium channel. So what happens? Sodium is entered more into the blood, more into the blood. Now let me clear here. Once entering the sodium, what happens? No, in the blood. Now what happens is that sodium will enter into the blood, and potassium will leave out by the help of ATPase. ATPase. This is normal process. If our drugs block this process, we will block this process. What happens? Sodium will not enter, and this pump will not activate. So the what happens is that sodium, whatever is present in the urine, will go out, and the potassium which is present in the blood will stay. So there is no further loss of potassium. Why? Because potassium has direct effect on cardiovascular system. When potassium in heart failure patient, no, potassium loss will be there. If potassium is there, no, what happen? Heart will function well. So what happened? The sodium, when you are blocking this process, what happened? This ENCA, ENAC, that is epithelial sodium channel. When you are blocking, what happened? Sodium will not be reabsorbed. At the same time, sodium potassium ATPase pump is not worked. So two functions will happen. Sodium, whatever present in lumen, will go out. It will be excreted, and the potassium which is present in the blood will be as such. Will be as such. This is how this spironolactone drugs will act. Now, so this is spironolactone. So you see, this is spironolactone. Spiro compounds means what? Two cyclic compounds. For example, you see benzene, cyclohexane, two cyclohexane, cyclo compounds having common structure, one carbon common, like this. Then they are called as spiro. You see here the spiro. And this is lactone structure. What do you mean by lactone? Cyclic esters. We learnt in our first year organic chemistry. Lactone. So that's why it is called as, the drug name is spironolactone. What is the nucleus? Steroidal nucleus. Steroidal nucleus. The trade name for this is aldactone or eprilone. Eprilone. What it is used in treatment of edema, antihypertensive, primarily combined together, thiazides. Then what is the side effect is that hyperkalemia. Potassium is spared, no, that's why hyperkalemia. And one more is that as it is a steroidal nucleus, it causes gynecomastia in men. That means what? Development of breast in men. In men, what happens? Breast tenderness and menstrual disturbances are seen in women, and minor GIT symptoms are the side effects. Gynecomastia means development of breast in men. So these are the symptoms of spinal actome. Hmm. Then still more drugs are there. Hmm? These are still spinal actone drugs. Then amiloride, one more drug. What is the amiloride here? You see, this is having pyrazine nucleus. This is pyrazine nucleus, and this portion is called as guanine structure or guanido. And NH2. Oh my God. NH2, NH2 is called as guanidine. This is amiloride. To get amiloride, you see how much they done, how much they suffered. You see, over 25,000 25,000 agents were examined in an attempt to describe anti-calculatic drug. Anti-calculatic drug means drugs which prevent potassium with no hormonal activity. Why? In previous slide we learned that these drugs are producing gynecomastia, irregular what is that, menstrual disorders. To avoid that, they were desperately searching for non-steroidal drugs. So when they searched more than 25,000 molecules, they got amiloride. Here, the sixth position is substituted with chlorine. This is SAR, direct, no change. The amine group at, at fifth and third position. Then guanidino. You know, no, CH4 is methane, CH3 is methyl. Actually, this portion is guanidine. Now it is substituted, no, so guanidino. And this group must be unsubstituted. Must be unsubstituted. Next, triamterene. Triamterene is, you see, it is having, what is this ring? Pyrazine. And this is called as pyrimidine. Both combined, it is called as pteridine. So P silent. Both combined, it is called as P silent. What it is? It is called as pteridine. So this is also one more good drug in potassium sparing diuretics. You can learn. Next, last. Osmotic diuretics. See, osmotic diuretics. Uh, Examples are mannitol, glucose, glycerol, urea. Now, what they do is that with these drugs, you see, they are mostly administered by IV route of administration. Let me go to that first diagram, then you will get understood more. Please do not leave. Now, for example, here. So, I told you this is the blood enters. So what happened? This mannitol, sugar, ammonia, what they do is that they are administered by IV route. What happens is that these substances are filtered at the glomerulus, at the Bloman capsule. When they are filtered, now what happened? They enters into the glomerulus. Enter here, but because of heaviness, no, here they will not be reabsorbed. They will not be reabsorbed maximum. So when they stay here, because of osmolality, what are these glucose, mannitol, all these are solutes. So what happens is that when solute is present here, solvent tries to come here because of osmolality. So the fluid, whatever present in excess, uh, will come to the lumen and get excreted out. This is the main mechanism of these osmotic diuretics. You might have learned osmotic purgatives. They are also same. Mannitol, IV infusion, concentrated glucose IV, 50% you see. Mannitol, glycerol, urea. So they are relatively net, given by IV, largely excreted without metabolism. Now they are filtered freely through glomerulus. So they undergo limited reabsorption in the glomerulus. What happens? They increase osmolality. So when they are present here, more solute. So water tries to come back. So when water comes here, what happens? It comes here solute, no. So water will come. Solution it makes, it gets excreted out. That's why, in our tradition, to a pregnant woman suffers from edema. So they perform a small function and give more sweets to her. More sweets to her. When you give sweets, no, sweets is nothing but glucose. What happens is that edema is reduced. And women, no, during pregnancy time, no, edema she gets sometimes diabetes. So if you get diabetes, you should not give this again. Huh? Again, no, this diabetes, hypertension, which women get during pregnancy, will be unseen after pregnancy. So during that period, you need to be very careful. That's why, no, in our tradition, we used to give sweets to women, and they perform small function. Hmm? So you people also should inculcate this culture and give. It's a proven science and behind why we give sweets to the pregnancy woman. Hmm? Because they prevent edema. So this is the way these drugs act. That's what we here you see. Mannitol, if it is present, it is solute. More water comes out. More water comes out because of osmosis. So water goes out. Water goes out. Next, therapeutic uses you see. Again, in acute oliguric uh, right ventricle failure, to maintain adequate glomerular filtration rate, uh, in oliguric renal failure, sorry, it is in oliguric means loss of water. uh, Oliguria means decreased urine. What happened? Decreased urine output is known as oliguria due to renal failure. In that condition we can use. In treatment of acute glaucoma, by decreasing aqueous humor formation, then reduce intracranial pressure. We can also reduce intracranial pressure. Then in hemolysis and rhabdomyolysis, in blood lysis and rhabdomyolysis, also we can use this osmotic diuretics. Side effects: headache, nausea, vomiting, hypernatremia. Then mannitol causes hypersensitivity reaction sometimes. Then glycerol is metabolized and causes hyperglycemia. That's what I was telling. If woman is suffering from diabetes, don't give this mannitol, this treatment. These are the side effects. One contraindication is that these drugs should not be given in heart failure. This osmotic diuretic should not be given in heart failure or pulmonary edema. Why? Because no, sometimes they go and stay in the lungs. These mannitol, they enter into lung and they stay. Now, whatever we have seen in kidney, no, it will happen in lungs. More complication. That's why in heart failure patients they should not be given these drugs. Osmotic diuretics are contraindicated. Are contraindicated. So these are the some questions you can read. So any doubt, please? Thank you for staying.
Hello, sir.
Madam.
I don't have any doubt, but I have a request to make.
Tell me.
Um, it's about the assignment. If you could extend the deadline a bit.
No problem. I will do. You people have to search and find means no problem.
Yeah,
So
there's a lot of research to do.
okay. Monday I given no
Monday?
deadline.
So one day only.
No, no. What is the deadline actual?
Oh, I think maybe you can give 1 more week.
1 more week, 2 weeks. It's not unfair, Srina.
So it is fair. Yeah, we have to go to uni the whole day. Then how do we research?
Okay, no problem. I will do it.
So next week, Sunday.
Okay, no problem.
Thank you, sir.
Hmm. From anyone, any request or any doubt? Okay then. Bye. Huh? Bye. I'm leaving.